Good morning, good afternoon, or good evening, wherever you are at this time. My name is Lei Fan. I'm a postdoctoral fellow at Vanderbilt University Medical Center. It's a pleasure to be with you all today. The title of my talk is Magnesium Treatment on Methylation Changes of TMPRSS2. I have nothing to disclose. Before jumping into the topic, I just want to acknowledge and thank our participants and research group that were involved in this study. I'm very fortunate to have access to the resources for the current study, which were derived from PCCCT, a randomized trial that a group of people had worked really hard to ensure the trial was successfully completed within 7 years. Their generous contributions have made all this work possible. The emerging highly transmissible Delta variant has changed our anticipation that the COVID pandemic could end this year. The Delta variant has turned out to be more than twice contagious as previous ones, and it is now responsible for over 99% of all cases, according to the latest data from CDC. Variants concern will continue to emerge, and eliminating coronavirus will be most difficult and expensive around the world, even in the presence of COVID-19 vaccination. The NIH highlights an urgent need for interventions which can be administered early during the course of infection to prevent disease progression to severe illness, speed recovery, and prevent long-term complications, particularly among high-risk population. Vitamin D has drawn most attention because vitamin D deficiency affects immune functions and has been associated with risk of respiratory tract infections, including influenza and pneumonia. In terms of COVID-19, evidence from observational studies are mixed and inconclusive. Some retrospective studies demonstrated a correlation between vitamin D and COVID-19 outcomes, while other studies did not find correlation when confounding factors were adjusted. A large-scale prospective cohort study in UK Biobank found that serum 25-hydroxyvitamin D was not related to risk of severe COVID-19. An open-label trial reported that a high dose of 25-hydroxyvitamin D treatment substantially reduced the need for intensive care support among hospitalized COVID patients. However, a recent randomized trial conducted among 240 hospitalized patients found that a single high dose of vitamin D3 treatment as high as 200,000 internet units did not significantly reduce the hospital length of stay compared with placebo. So the evidence regarding a single vitamin D treatment for COVID-19 has been inconsistent. In 2018, we reported in a precision-based randomized trial that an improved magnesium status led to an optimal level of vitamin D. As you can see from the figure, magnesium treatment increased circulating vitamin D levels to an optimal range when baseline vitamin D levels were low, but reduced vitamin D levels to an optimal range when baseline vitamin D levels were high. A recent randomized trial in Spain further confirms this finding. During the COVID pandemic, a recent study conducted by Dr. Tan and his colleagues found a combination use of magnesium, vitamin D3, and vitamin B12 called DMB reduced the risk of severe illness from COVID-19 by 80%. This is the only evidence of magnesium-involved treatment so far conducted in COVID-19 patients from an interventional study. It raises the question that whether the synergistic interactions between magnesium and vitamin D may reduce the doses required for vitamin D to take effect, or magnesium rather than vitamin D directly lead to the protective effect. Obesity, insulin resistance, and type 2 diabetes are important risk factors for severe cases and death in COVID-19 patients. It is known that magnesium deficiency leads to insulin resistance and type 2 diabetes, and as many as 50% of type 2 diabetes patients have hypomagnesemia. A better understanding of the role of magnesium in the prevention and treatment of COVID-19 will benefit the vulnerable population with type 2 diabetes that are at high risks of magnesium deficiency and severe illness and death from COVID-19. In this groundbreaking paper published in Nature Medicine that came out in 2020, TMPRSS2, a cell surface protein that belongs to the serine protease family, are highly expressed in nasal goblet and ciliated cells. These cells are locations of original infection and possible reservoirs for dissemination within and between individuals. Then another publication in Cell reported that the viral entry of SARS-CoV-2 depends on binding of the viral spike proteins to ACE2 receptor. This binding process requires TMPRSS2 protein to facilitate viral spike protein priming. In vitro studies showed that TMPRSS2 inhibitor primarily blocked SARS-CoV-2 from entering into lung epithelial cells. And animal studies found that TMPRSS2 knockout mice infected with H1N1 influenza had minimal infection and a largely attenuated disease severity. This indicates that TMPRSS2 may share a common mechanism in facilitating different viral infections, including influenza and COVID-19. Then a publication in JAMA reported that African Americans had significantly higher nasal epithelial gene expression of TMPRSS2 compared with other racial ethnic groups. High viral loads can induce cytokine storm, which triggers a violent inflammatory immune response that contributes to acute respiratory distress syndrome, multiple organ failure, and finally death in severe cases. This may partially explain why African Americans were disproportionately affected by severe COVID-19. The science community noticed another interesting phenomenon. A number of ICU physicians reported that over 31% of ICU patients and half of severe cases infected with coronavirus developed thrombotic complications, including pulmonary embolism, which is the most common, and deep venous and arterial thrombosis. A publication in New England Journal of Medicine found that lung autopsy specimens from patients who died from coronavirus were distinctively characterized with widespread vascular thrombosis. These thrombotic complications are serious threats to patients, and they can cause organ failure and even death. As we know, high viral loads induced cytokine storm in the bloodstream triggers inflammatory immune response and a coagulation cascade. But what is the role of TMPRSS2 in the thrombosis formation? Once TMPRSS2 is activated, the domain of TMPRSS2 is released from the cell surface into extracellular space. The cleaved active TMPRSS2 protease can thereby activate the PAR2 signaling pathway. PAR2 is also known as coagulation factor 2 or thrombin receptor, which plays a central role in the blood coagulation cascade. And TMPRSS2 inhibitors such as nefamostat has already been used in clinical practice as an effective anticoagulant even before the COVID-19 pandemic. Camostat methylate is another closely related compound that are undergoing clinical trials to test their utility for COVID-19 treatment. These evidences reveal the important role of TMPRSS2 in regulating thrombosis and in turn disease severity. Strongly upregulated TMPRSS2 gene expression was first observed in prostate cancer, consistent with racial disparities in nasal epithelial gene expression of TMPRSS2. African Americans also have higher incidence and mortality of prostate cancer than European Americans, indicating that the high prostate cancer mortality among African Americans may be attributed to upregulated TMPRSS2 expression. However, factors that may impact modified TMPRSS2 expression remain unknown, and low magnesium status could be one of these factors. Ours and others' previous evidence found that African Americans had significantly lower levels of serum magnesium or lower intakes of magnesium compared to European Americans, while low blood magnesium levels and a high calcium magnesium ratio diet were significantly associated with high-grade prostate cancer. TMPRSS2 expression is influenced by both genetic variants and epigenetic changes. We all know that we cannot modify our gene information, but DNA methylation changes can be made by environmental exposures, including nutrients. DNA methylation is chemical modification that attach to the backbone of DNA and mark the genome. 5-MC and 5-HMC, the newly discovered 5-HMC, are the two major types of DNA methylation. They're like yin and yang, day and night, switch on and off. And 5-MC means the methylation of the fifth carbon of cytosines is associated with transcription repression. On the contrary, 5-HMC is critical in maintaining active gene expression. Conversion from 5-MC to 5-HMC is a demethylation process, which means more genes are open to expression. Magnesium affects the metabolism of one key factor of the 10-11 translocation enzymes called alpha-ketoglutarate. And alpha-ketoglutarate catalyzes the process of 5-MC to 5-HMC in the demethylation pathway. And despite of that, we know very little about 5-HMC and the role of magnesium in regulating 5-HMC. The CpG sites are locations with DNA methylation markers, and the CpG-rich islands mostly exist within or close to the promoter region. They are capable of initiating transcription and regulating gene expression. 5-MC in promoter region will lead to repressed gene expression, whereas 5-HMC in the promoter region will lead to active gene expression. PCCCT is a precision-based magnesium supplementation trial. We previously found that a calcium-magnesium ratio diet at around 2.3 brings about the best health benefits. So we targeted lowering calcium-magnesium intake ratio to 2.3 via a 3-month personalized magnesium treatment among those who consumed high calcium-magnesium intake ratio diets, but were otherwise in good general health. The study was completed with a high compliance, and the dropout rate was very low. The treatment arm and the placebo arm are balanced across demographic characteristics at baseline. The mean daily dose of personalized magnesium supplementation were around 200 milligrams. Compliance with the pill regimen were very high for both arms. The mean calcium-magnesium ratios after administering magnesium supplementation were around 2.3 and remained stable during the 3-month treatment. So now I'm going to show you the overall 5-MC methylation changes, overall 5-HMC methylation changes, and the stratified analysis respectively. This table shows the overall 5-MC methylation changes after magnesium treatment in 32 CpG sites. I wanted to focus on the CpG sites ended with 1860 marked in red. The CpG 1860 is located at a CpG-rich island 200 to 1500 base pair upstream of the transcriptional start site. These loci within the promoter region of the gene play an essential role in transcription initiation and regulation of gene expression. We found that compared to the placebo arm, magnesium treatment significantly increased 5-MC level at CpG 1860, even after adjusting for age, sex, and baseline level. However, the significance disappeared after FDR correction at 0.1. For 5-HMC, we found that magnesium treatment affected CpG 1860 compared to the placebo arm after adjusting for age and sex, but the effect was not significant after further adjusting for baseline levels. Another CpG site ended with 7277 resides within 200 base pair upstream of the transcriptional start site and the 5 untranslated region. We found that magnesium treatment reduced 5-HMC at CpG 7277 compared to placebo arm after adjusting for age, sex, and baseline levels, but the effect disappeared at an FDR correction of 0.1. Aging is strongly correlated with changes in DNA methylation, which means individuals in different age groups may have different epigenetic responses to magnesium treatment. In stratified analysis by age, using a cutoff of 65 years old, personalized magnesium treatment significantly increased 5-MC methylation at CpG 1860 by 7.2% and reduced 5-HMC level at CpG 7277 by 2.3% compared to placebo arm after adjusting for covariates in those aged less than 65 years old. Both effects remained statistically significant after adjusting for covariates as well as FDR correction, and the effect was not significant among those aged 65 years or older. In summary, in this precision-based randomized trial, 12-week of magnesium treatment significantly increased 5-MC modification at CpG 1860 and decreased 5-HMC modification at CpG 7277 in the TMPRSS2 gene compared to placebo among participants aged less than 65 years old. This indicates that younger adults are more responsive to magnesium treatment through the TMPRSS2 pathway. Although no significant effect was observed among those aged 65 years or older, it is likely magnesium treatment may exert benefits through other mechanisms. First, vitamin D has been proposed to generate beneficial effects through activation of the vitamin D receptor signaling pathway by reducing the cytokine storm, maintaining the integrity of pulmonary epithelial barrier, and and tapering down the increased coagulability. Magnesium may optimize body vitamin D status and substantially reduce the doses required for vitamin D to take effect. Second, magnesium may have beneficial effects in boosting antivirus immune cells. Previous studies show that magnesium deficiency caused by a gene mutation led to reduced cytotoxic activity of T cells and increased viral load. Another study found that magnesium treatment reduced B cell infection for EB virus. We should be cautious interpreting the findings from the current study. The primary concern is that TMPRSS2 expression was not measured in the PCCCT, and thus the association between DNA methylation changes and a level of TMPRSS2 expression and phenotype patterns is not confirmed. Yet, the observed DNA methylation changes were internally consistent, with increased 5-MC and reduced 5-HMC, indicating a reduced level of TMPRSS2 expression is possible. Second, this is a post-hoc analysis of a randomized trial that enrolled COVID-free subjects. It is an exploratory study aiming to advance our understanding of the potential role of magnesium in the mechanism of SARS-CoV-2 infection. Future studies are needed before the findings can be directly applied to COVID-19 patients in clinical settings. And future studies are warranted to investigate other magnesium-involved pathways for the prevention and treatment of COVID-19 among older adults. Studies with combinatorial use of magnesium and vitamin D for the prevention and treatment of COVID-19 among older adults are also needed. Our findings also indicate a possible mechanism of magnesium involved in prostate cancer and influenza. I'd like to acknowledge and thank my mentors, colleagues, and collaborators. Their generous contributions have made all this work possible. Thank you for your attention.